Well, good afternoon. I appreciate the invitation to come and speak with you. A couple of things. Dr. Cabela and I did not compare notes before our talk, but you're going to hear some surprising, perhaps overlap, and some continuing themes. I'd like to thank Runcie, who thought that we're in a conference where we are celebrating advances and triumphs in ovarian cancer, and I'm up here to talk to you about anxiety and depression. And a lot of times in conferences like this, you won't hear a conversation because I talk about things people don't want to talk about.
For just a second, you have to hold on. There you go.
There we go. I'll circle back to that in a second on one of my slides. So it's an issue. I mean, anxiety and depression are part of the deal. And if they're not dealt with, they definitely can have an adverse effect on cancer and health in other ways. So what I want to do is just talk a little bit about anxiety and depression generally, especially as it relates to ovarian cancer, and some things that are relevant to the current research and things that we can do to bring this subject out into the light. I've been doing this work for about 30 years, and the needle has nudged a little bit, but the stigma associated with mental illness, even though a lot of what we're talking about this afternoon is not classically hardcore mental illness, emotional distress is still something that is value-laden and is effectively a disparaging type of comment. And Dr. Cabela talked about that a little, and I'm gonna, a big part of what I think my job is to be an advocate, so I'm going to sort of pound away at some of this stuff as we go through the talk. So the National Comprehensive Cancer Network Distress Panel, on which I sit, has sort of defined emotional distress in this way. It's multifaceted. It can be emotional, it can be social, it can be spiritual, it can be existential. And it may interfere, though as I will show you, for the most part, it doesn't interfere with an individual's ability to cope with cancer and with its symptoms. So everything in psychiatry or in mental health psychology, it exists like on a continuum. So it can be something from just having a bad day, right? Or the Astros lost, or you're not feeling good about a lab number that you got back, but it sort of gets you down, but things get better. But both in medical care and the care of ovarian cancer, and certainly in public health generally, it can also go to the other side, to full-blown disorders such as depression, panic, and then existential and spiritual crisis. So if we look at numbers, this study is going back about, 20 years. This came out of Johns Hopkins, looking at emotional distress at levels that were thought significant enough that intervention was warranted. And as you can see, this was, if you looked at all comers, about 35% in open trials, patients had a level of distress that was thought significant, that they really needed to see somebody. Okay, bad news. That's a lot of people, and especially for cancer, a lot of, especially community cancer centers are not set up, they don't have the personnel to deal with this. Good news, part of what I want to do about myth busting today. Everybody who gets cancer, ovarian cancer, doesn't get depressed. And everybody who gets ovarian cancer doesn't get so anxious that they can't handle it, right? I'm aware of physicians who, on the diagnosis of cancer, along with the initial therapy, also prescribe an antidepressant, which is a total crock. They're doing it based on their own fears and assumptions about what their patients are going to be able to do with a cancer diagnosis. But there is a lot of distress out there. And we're going to talk mainly about anxiety and depression. So depression is this big grab bag term, right? It's this big, huge umbrella. In some of the research that I'm going to cite, the term depression can mean various things depending on the rating scale that is used. So the one that we're most concerned about, and this is a major public health problem, is major depression. I'm going to show you the diagnostic criteria here in a minute. So, and these conditions can look identical until you get together with somebody who can tease this out. This is part of the problem, you know. So it can be major depression. There are actually some diseases that will induce depression. It's been associated with certain cancers, pancreatic cancer in particulars, though I'm not sure about that. Certain endocrine disorders, thyroid disorders, lupus for sure, that it's part of the disease process. So, and there are definitely, and a big part of my job is treating the psychiatric side effects of our therapies. And there are definitely, especially some of the older anti-neoplastics, where there was a high risk of depression associated with these. So it can be that, okay? It's probably going to be this in a clinical in a clinical scenario. It's going to be adjustment disorders. It's going to be maladaptive coping. I'll show you the diagnostic criteria there. And I'm going to show you something called demoralization, which people probably go through, but they don't conceptualize it. And demoralization can be a very dark place to be in. But as I'll show you, the good news is there's some really effective therapies for it. And then something else that happens, I think it's not, you know, in my clinical work with lots of patients, I think there's a lot of grief. And grief is not a bad thing. Grief leads to healing. And I'm not trying to be all rosy about that. I think it's factually correct. But it's also sort of more normalized. Okay, it's okay to grieve, but it's not necessarily okay to be depressed. And we can grieve for things we can grieve for the future. We can grieve for things that we actually know we're going to lose, or we think we're going to lose, but we really don't have the evidence for that yet. So, problem is, all of these things, to first approximation, can look identical. So here are the criteria for DSM for major depression. This is the most difficult and serious of the disorders. Patient needs to have persistent depressed mood or persistent lack of interest in activity, or both. And as you can see here, also there's a sort of cookbook list of physical symptoms, including weight gain or loss, sleep problems, fatigue, psychomotor agitation, diminished ability to think. You can see that this is potentially a fairly difficult diagnosis to make in a patient who's actively being treated, because a lot of the symptoms of major depression could be attributed to the illness itself. So sometimes this can be a fairly difficult diagnosis. Right now, this is 4% of the American adult population at any one time. In any study you care to name, there would be twice as many women with major depression. It just rolls out that way. 1 in 5 Americans, 20% of Americans, adult Americans at any one time with some symptoms of depression. It is a pervasive mental health problem, 3% lifetime risk of suicide. So it's out there. Demoralization, and interesting problem, unless you have it. It's the concept of loss of hope. And individuals have loss of hope as a generalization can lose purpose. And we see this a lot across the board in advanced cancer settings, potentially in end-of-life settings. So with that comes this feeling of being a failure, or potentially. And I will see patients who tell me, "Doc, I'm not depressed, I'm not sad, I got nothing to live for." So, and individuals in studies largely coming out of Sloan Kettering and with our colleagues in Winnipeg find that patients with demoralization have an increased risk for death. And it can be, I've had conversations where there's a logical alternative. So, and there are these other symptoms. This is an area that my department, my colleague Jerry Ignatius, has an active research interest in trying to tease out folks with this. Really tough problem, but it is very amenable to an intervention called meaning-based psychotherapy that came out of the work of Viktor Frankl, who actually practiced psychotherapy in Auschwitz, where he lost his family, but he was a psychiatrist. And he found that even in the face of atrocity, it was possible to have meaning. And meaning-based psychotherapy is very effective in helping individuals who are demoralized. As far as anxiety, here are the symptoms. I know I've experienced these, you might have experienced these, but anxiety is experienced both in a physical way and also in an emotional way. Usually in health, we don't have, there are settings where one can be anxious and sort of be happy, like you're anticipating getting married, you're nervous, but something good's going to happen, you're getting ready to go in a ball game. But in the setting of healthcare, this is usually ego dystonic. If you're anxious about your health, you'd rather not be. And it is a physiologically aroused state, which will have something to do with some of the work that's associated with anxiety and depression in cancer and ovarian cancer. So anxiety disorders hit early. Most individuals who have various anxiety disorders are going to have them by 25 or so. And in fact, as you can see, it's a sort of busy slide there. It's actually a disorder, the various disorders that hit children. So 50% of individuals who have anxiety disorders can have them by the time they're their teens. So with notable exceptions for purposes of our talk today, this disorder and also cancer are going to hit, and also depression are likely going to hit earlier than cancer, with some exceptions. So adjustment disorders then. This can look like depression, but this is largely reaction to a stressor, like a cancer, like a lab value, like a divorce, like whatever. And it causes symptoms that cause impairment in function. So the psychiatric diagnostic nomenclature really gets criticized because this is highly subjective. So everybody in the room, given the same stressor, might not react the same way. And for some, it would get to a point where it's tough to cope, where the gear gets stripped. So, and actually most of the time in clinic, this is what we see the most. We see the emotional symptoms, but not the physical symptoms. So this is quite common. So levels of depression by disorder. This is an ovarian cancer conference, and either because women are more susceptible or more willing to talk about it, we generally see that in about any cancer disease site that you care to name, we're going to see higher levels of depression in women than we are in men. In the general population, take cancer out of it, twice as many women with depression as men. Okay? And this is something that seems to bother younger individuals. We see lower levels of depression as age increases. Okay? With age comes wisdom, with age comes experience, with age comes having solved problems, and I'm going to come back to that. So, and you do see that, my bad eyes here, that even in diseases where it's both men and women with the same disease outside of ovarian cancer, you're going to see higher levels of depression, but in younger women. For anxiety, it really skews. So much higher levels of anxiety in women than in men. There may definitely be a reporting bias. Men may not sign up for studies that they're willing to talk about it. So, it's a little bit difficult to know quite what to make of that. And the same thing, higher levels of anxiety in younger patients across the board, and for purposes of our conversation, younger women. So if we look then at ovarian cancer, this is a review study that's a few years old, just looking at prevalence levels across multiple studies, some of which I will come back to, and finding that prior to treatment, overall prevalence of, let's see if this will go back. So overall prevalence levels of anxiety, about 20% for anxiety, and actually for depression prior to treatment, if you take these gross studies, ticks up into the 20 to 25% range. High levels of depression and anxiety, 3 to 4 to 5 times that of the general population, but not 50%, not 75%. Most folks are doing pretty well, but we need to turn our attention to those who aren't, because that's a lot of folks. So on treatment then, understandable levels of anxiety. We're going through the treatment that everybody's been talked about. This is highly stressful, it's including emotionally stressful. Is it gonna work? It's just a drag, right? And for the most part, after treatment, depression levels come down, but fairly consistently in studies, anxiety levels hold up there in the 25 to 30% range across the study. There are some outliers, and I haven't dug into these studies to find where a couple of these got really high. So what I wanted to get to next was the general concept of stress, and a lot of work has been done on stress related to cancer, And a great deal of it has been done by Dr. Sood, who's arguably one of the world's experts on this. And since I get to work at the same hospital with him as a psychiatrist, I've had this interest, like, well, at the basic level, there are these relationships. Well, how does that play out at my end, where I'm on the opposite end taking care of very anxious and stressed patients? So there's been some really amazing work done by Dr. Sood and his colleagues going back 15 or 20 years looking at stress hormones and their effects on ovarian cancer, or on the way that ovarian cancer can progress, showing that inflammatory hormones, certain neurotransmitters affect the biology of ovarian cancer at a minimum in the petri dish, and quite possibly in the mouse and in the human subject as well. So this has gone on, and what I did was basically just cherry pick some of these studies. It's fascinating work that goes on. And this has also been looked at in depression, and there's a lot of, among the reasons to be interested in this is because of the concept of inflammation, which is a very hot topic, as I will show you here in cancer, and it's also a hot topic in primary depression. So Dr. Ludendorff and Anil and his colleagues have looked at these levels of inflammatory chemicals related to depressive symptoms and how the cancer is progressing. And there's a lot of studies on this. So I just cherry-picked a few to show you that this is an active area of research and potentially for intervention. A fairly recent study by their group has shown that there is at least a modestly higher rate of depression in patients with ovarian cancer. That personally doesn't shock me, but it was well documented, and so we put some numbers onto this that really gives us some certainty to work with. And I actually found a couple studies that Neil's not on, one coming out of Poland that looks at levels of anxiety and depression, showing as well that the depression levels go down with time, anxiety levels holding up. And then a study out of China that has shown, it's a smaller study showing higher levels of depression related to more advanced stages of cancer, and unfortunately with an adverse outcome on survival. So a lot of work on this. Overall, stress is probably not good for cancer, right? So in another review that did not include ovarian cancer, various stress factors, including basically poor coping, were adverse indicators for incidence of cancer and for cancer survival and for cancer mortality. They're not massively bad, but this emotional stress is, I mean, it's a gross simplification, largely not good for the body. And I was asked specifically to comment on a study you might have seen that came out of the first of the month out of the Harvard group, showing that in a large nurses study over 20 to 30 years, that increasing levels of symptoms of post-traumatic stress increased risk for ovarian cancer to the point of doubling it. That's getting a lot of press right now. The authors themselves have been responsible enough to say that it's not quite that simple. These are self-reported symptoms as opposed to being diagnostic, but it's statistically out there and in some ways makes a lot of sense. So I think this deserves further study. What I get worried about is people thinking I've got whatever anxiety or depression and therefore my disease is going to go rampant, and I don't think that there's any data to support that. And in fact, with regard to the question of health disparities, patients with severe mental disorders, by and large, either don't get cancer as often as the general population or about equal. But if they do get cancer, the mortality rates are consistently worse. That may be biologic. Patients with severe mental disorders may also be a group within health disparity who have lack of access. In the Australian literature, they do not come to surgery as quickly, especially not for head and neck cancers. So, but for instance, in schizophrenia, outside of lung cancer, schizophrenics don't get cancer as often, and there's a question of a genetic correlate. So, interesting type of issue. And we don't know, though, why, if patients have severe mental disorders, they don't tolerate treatment, they don't get to treatment, they're more genetic, they're more vulnerable. So it sort of goes together in a recent paper looking at this idea that psychosocial stress related to Dr. Sood's research could lead to greater inflammation, to permeability into the gut, so that you've got really bad bacteria that are getting into the general circulation, dysregulated hormonal activity, and decreased immunosurveillance. The problem with this is I don't think all of these are one way. I think that dysregulated HP, there are individuals who've got basically dysregulated hypothalamic pituitary adrenal axis at baseline and are therefore more vulnerable to depression. I think that there are some individuals who have basically suboptimal gut flora and are vulnerable to depression. Some places are now starting to look at fecal transplant for severe depression. So this is not all one way. My concern is that this idea is that our minds are making our bodies sick. Well, otherwise, sometimes it goes the other way too, because if your system is not set up right, it will then have effects on how the possibility that you're going to get depression or some sort of disorder. And it really isn't as simple as we would like it to be. In the study that showed all of the risk for increased risk of cancer and mortality, Cheetah said that stress is multifactorial and is a product of exposure and the human response to it. And that's going to be the rest of my talk. And when Dr. Wang, working with Dr. Sood in their most recent papers, one of this great comment, and I just cherry-picked it out of there, exposure to chronic stress may not necessarily result in a bad biological response, depending on how one perceives the stress. They cited the large national nurses study that has tracked ovarian cancer over 20 years. Some of those nurses are saying, yeah, we got a stressful job, but we love it, and we are helping people. So it's not just the hormones, and it's not just the neurotransmitters, it's how you handle it. So stress goes with life, stress goes with cancer, but we handle it in different ways. So, okay, so where do we go from here? What do we do with all of this stuff? I have to talk really fast here. Okay. Well, as we've talked about, this is stressful. Okay? My stress hormones right now are really up because I can't run a machine, okay? There are some people who say you shouldn't talk about this stuff, and this came up with Dr. Cabelli, right? There's other stuff going on there. People who are saying this are scared themselves, and they don't want you to talk about it, right? So there are emotional, cultural, spiritual, religious, whatever. Sometimes when people are being told, don't talk about this stuff, it's for other reasons, okay? No one is invulnerable. Watch out for those who say they are. I'm going to really go fast here. If I can get this to go, there it is. All right, it's appropriate that I'm holding this microphone. This is a photo of Dr. Judith Holland, who single-handedly invented the field of cancer psychiatry in the 1970s. I didn't train under her, but I was fortunate to work with her. She was one of my mentors. She's a little Texas girl from this town outside of Dallas. And Jimmy is very aggressive. Don't let that picture fool you. She could. And Jimmy always said, Alan, get closer to the microphone, which is, so Jimmy had this, and unfortunately this is from her obituary. She died on Christmas Eve in 2017. And as a leader in the field, she deserved a New York Times obituary. She talked about this sort of thing, the tyranny of positive thinking, which is a little bit counterintuitive. Jimmy very definitely wanted people to have a positive outlook, and I just think it's easier if you do. But it has to be coupled with competent medical care, with being cared for by people who know what they're doing. And this thing about don't worry, be happy doesn't cut it. Jimmy said this, it's bad enough to have cancer, but when all of your family and friends are saying that you have to be positive and you have to fight this thing, and the patient is exhausted and beaten up the treatment, it seems to me that adding that burden to be positive was just ridiculous. And that is so typically Jimmy Holland, and she was so right. I had a pinch hit for her at a lung cancer conference in Kansas City, and I brought this up, and those people didn't want to hear it because that was a cheerleading conference, and I nearly got run out of town. But Jimmy's right. We can talk, but it was, some people, the imperative only makes things worse. And it's magical thinking to think that if one is positive, everything is going to go right. That's not the real world. What do we need to do? We need to cope. What is coping? Coping is problem solving in real time. And with that, we can have hope. Folks who are demoralized don't have hope. Hope is the possibility of achieving a goal. And how do we do that? We do that by having resilience, the ability to respond well and in the face of stress or trauma. Everybody in this room has resilience. If you didn't, you wouldn't be here. Okay? But resilience can wax and wane. Okay? But we all have it. Frankl showed that it existed at Auschwitz. But sometimes it's in short supply when you sort of need it. So, adjustment disorders. Jimmy said that the best way to cope with the current stress, especially if one has had life experience, is to go back to things that worked before. So you don't go back to drinking if that's what you were doing before. But a lot of us have been through stresses. We've been through losses. We might have been through cancer the first time. Okay? Something got us through it. We've got skills. But sometimes they're just a little hard to access. So do this. Ditch the value judgments. Okay? My advocacy is the stigma. I have no tolerance. I understand it, but I don't have tolerance. And the shoulds and the musts and the shame. There's no place for that in 2019. I get my inspiration from everywhere. Voltaire said, "Do not let the perfect be the enemy of the good." You don't have to be on your game all the time. You may not. It's not maybe a question of being not depressed. Less depressed is a good start. That'll get you going. 38 special. Just hang on loosely. Okay? All right? You can overdo it. That imperative must. Okay? And what we all do. I never served, but I admire the Marine Corps. Improvise, adapt, and with that, you will overcome. Okay? This starts with self-awareness. We've talked about health-promoting behaviors, group validation, limit setting, saying I don't have to do this all the time, or I don't have to listen to this all the time, but it's important. I'll come back to it tomorrow. I won't devalue it. Communication, and there's some individuals who should get professional assistance with this stuff. So I think this is my last slide. Next to last slide. Lots of ways to go about this. We've heard some about complementary and integrative medicine. Exercise now, I prescribe exercise for anxiety patients as an anxiety sink. I want it sucked away. It's actually being prescribed now for depression, partially for anti-inflammatory purposes. So faith and spirituality for some, but not for all. Okay? I don't have any tolerance for the assertion that anxiety, depression, or any other mental or emotional problem is a function of inadequate faith. And I hear that, and I think that's reprehensible. I think sometimes it's possible for one to not find it hard to access their faith. Psychotherapy, and in the right settings, medications. Patients with major depression should be on antidepressants. There are a couple prominent docs in town who don't believe that. They are categorically wrong. Anti-anxiety medications can be effective. If one is too severely depressed or too anxious, you can't do the rest of this stuff. So the idea is to use these medications to solidify the foundation so you can push off and do the non-medication things. And there's some focus things here. In certain settings, our colleague Eileen Shin at MD Anderson had looked at younger patients and found that younger ovarian cancer patients, lower socioeconomic groups, higher levels of general stress, had higher fears of dying. And she did something sort of unusual in that paper. Dr. Sood and I are on it. She has sort of editorialized that these patients should not be told not to talk about what they fear. Okay? That if an individual fears dying, it's okay to talk about it, because this magical thinking that if you talk about it, it's going to happen. So Eileen is an amazing advocate for her patients. Some individuals have higher levels of stress. The Canadian literature showing, especially on fear of recurrence, that gain is higher for some. If that can be targeted, that can be brought down. The Australians have done a lot of work on regimented protocols to help with this. And then this thing about external locus of control. Some individuals feel rather helpless, they have no internal control. And if those individuals can be identified, psychotherapy can be really helpful to deal with this. So that is in fact my last slide. I appreciate you putting up with my computer incompetence here, and thank you for your attention.